So you want to find the inferior part on one side, superior part on the other side, and vice versa to figure out the position of the sacrum. Just don't forget to palpate, and always when you're palpating the sacrum, make sure you get proper consent, make sure your patient understands where you're going to touch and what's going on, and be open that somebody will tell you they're not comfortable for you to touch it, and just you have to find other ways to treat it. There's always other ways to treat it. You don't have to use that. For example, if somebody doesn't want me to touch their sacrum, and I have to open up their sacrum with pressure, what I do, I have these small pillows that I have. They're not fully pillows. They're something between pillow and like a lacrosse ball. They're pretty solid. It's like a harder kind of a plastic. And they come, what I have is in different shapes and sizes. I pick one of the small ones, have the patient in supine, and just put it there under themselves and ask them to lie down on it for a few minutes. Just again, the gravity will pull down the sacrum and open it up. It's not ideal, it takes more time, but then you have to respect your patient's wishes, religions, or for whatever reason they don't feel comfortable with you touching that area. I've had clients who've had histories of being assaulted and stuff like that. They're not comfortable with you touching them around their hip area. You always need to have options for them to receive treatment, because you cannot just them, okay, I cannot touch your back, you can go get out of my clinic. You have to find solutions, and there's always solutions. You can show them movement. When somebody tells you cannot do this, you just have to become creative and find other ways to get the same result. It might take longer, maybe 2 extra sessions, 3 extra sessions, but that's the way that we need to go. Okay? While I have the patient in this position, anything else you guys want me to show you? So generally speaking, we didn't cover lumbar moves and stuff, but generally speaking, the one that I really like to do on everybody, and I start doing it on everybody at the beginning of a stage, beginning of treatment, if they have any problem on their spine, is catwalk. Just do it really light touch, and it's just your palms. This table is too high for me, so I'm gonna need to go on my tiptoes, but you go down. So this is the spinous process. It's not rotating the TVPs, it's TVPs posterior to anterior. So your shoulder needs to be right on top of your wrist. So table should be low that I can go on top of it, and you're just directly pushing down. So I find the spinous process, my palm starts on top of the spinous process. Take the skin slack out to be just right on the side of it. You don't want to be too far off away from it. Remember, the TVPs is 2 fingers to the side of your spinous process, the size of the patient's finger. If you're too far away, you're going to be on soft tissue, or if you're higher, you're going to be on the ribs and you're going to be on the scapula. So this is as much as the space as you have. So you need to be right on next to it, and then you just push it down, and then you switch and you go up. Something that I really do a lot, because all of us, if you're laterally bent, we should be all laterally bent to one side a little bit, because if you drive a lot, you're leaning to the side. If you're sitting behind a computer, we're leaning to one side either way. So everybody's a little bit rotated. As we talked yesterday, if you're rotated, if you're laterally bent, we're also rotated, right? Either way. So I want to work through the rotation of the spine as well. What I like to do is I grab one side of so this side, I'm going to be on the lateral side of the spinous process like that. On the other side, I'm going to be on the opposite side. I'm going to start far away, and I'm going to rotate downward. I walk it a little bit, and then I get closer. And as I get close to each other, I do it a little bit longer on each stage. I do it a few times, right? I'm doing it fast. Then I do the opposite. And I slowly get away. This is just an easy way to start moving, because again, every time you want to do osteopathic treatment on somebody, you need to make sure the tissue, the fascia, the joints, everything is ready for your treatment. You cannot just grab and let's start push on it and create mobilization by force. But there are techniques that you can put force on it if the joint is not moving at all. For example, if one of the spinous TVPs is not moving, I've tried everything is not moving, yes, at that point I use my PC4. I cup my, every time you use your PC4 for any technique, you need to cup your hand, otherwise you're going to dislocate your PC4. So always, if you want to use PC4 for localized pressure, you cup your hand a little bit for this to get locked. If it's not locked, you can move it, you can see how unstable it is. And if you create pressure on it, it's going to move out of place, and then you're going to be done as a manual practitioner for the rest of your life. So always cup it, and then you find that joint that is not moving, and then you can create force on it. And push it, you can ask the patient to take a deep breath in, and as they breathe out, you can create more pressure and force and go down through the range of motion. You can do all of these beautiful things, but do not start with them. Try everything else, work through the tissue, fascia, get the body ready, and if still you see, oh, this is not moving, then you can create force on it. the body is ready for it, the muscle tissue is ready for it, the blood flow is in the area, the body is ready for healing, and then you can create more force. Don't start with a lot of force. A lot of practitioners think that if I put a lot of pressure, I'm going to get there faster. You won't. You're going to create more inflammation. The patient is going to be in more pain, and usually the session is going to take longer for you to heal because you're going to fight the inflammation that is happening as you go through the body. Instead of relaxing something and moving to the next step, you're creating more inflammation as you mobilize in this, and when you move to the next thing is more inflamed than before. So you want to reduce inflammation, so don't create force as much as possible. And last thing that I'm going to say before we start doing assessment together is that you guys need to make sure that you have a proper understanding of the whole body. I don't care the first session the patient comes to you with a neck pain. You need to do a full visual assessment. You need to check the major muscles coming up, because even if the patient comes to me with any kind of upper back pain, neck pain, shoulder pain, you cannot go through the patient's body and do assessment without checking hamstrings. Like if we sit a lot and hamstrings are compressed a lot, it changes the position of your pelvic. If it changes the position of pelvic because of tightness, and I'm going into a posterior tilt, I'm overstretching all my posterior muscles on my back, so everything is being pulled down. So if you're doing that, no matter how much I try and work on this, nothing's gonna happen. So always have a good understanding of all the muscles of the body before we go through. Obviously, if the patient is not here for an ankle pain, I'm not gonna check all the attachments of everything around there. But the big muscles, the calves are having a good tone, the hamstring is doing good, check glutes, check performance to make sure they don't have a lot of trigger points in them. Go through QL, find all the trigger points that are major ones to see if they have a lot of them. As you go through, you need to do a full assessment. If you wanna have a short treatment, you need to have a full assessment. Or we can just do every muscle of the body and just decide that I'm gonna mobilize everything. I have an hour to with the patient. I'm gonna mobilize everything.